Good evening, everyone. Welcome to this webinar entitled Understanding Occupational Musculoskeletal Injuries in Ultrasound Providers and Sonographers, presented by Dr. Yusef Sayeed and Tammy Stearns. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to recognize the risk factors for occupational musculoskeletal injury, understand common injury patterns in those who utilize ultrasound, learn preventative measures to reduce occupational work injury risks, and understand how to navigate the workers' compensation system for repetitive injury patterns. As an ACCME accredited provider, it is the AIUM's policy to ensure that the content and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Yusef Sayeed, Tammy Stearns, and Darcy Belito de Luna have no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenters, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenters will not begin answering until the end of the presentation, at which time they will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Dr. Yusef Sayeed and Tammy Stearns.
Well, thank you for that kind introduction, Darcy. That was fantastic. So, today's webinar we're gonna talk about these musculoskeletal injuries in providers and sonographers. First, I want to mention just a couple of things in terms of my disclosures. As Darcy said, I don't have any financial disclosures. I also want to just say that my opinion is my own opinion today. It doesn't represent that of the Veterans Administration or Western Michigan University. And what we're going to discuss here is we're going to review a lot of the literature, the evidence, and discuss the best ways to avoid these injuries, as well as some clinical interpretation. So welcome everybody, and we're really looking forward to the discussion at the end. So please be ready with your questions. So, just to discuss some of the background, there's been a number of articles that have been published in the last 10 to 15 years, and here's just an example of many of them, and I'm happy to provide references at the end of my talk. In addition to a lot of the survey evidence that we've done, there's also evidence that I cite from the Bureau of Labor Statistics, which is from the Department of Labor. So this is the formula for repetitive motion injuries, and I'm not going to read off the slide, but as you can see, the number of repetitions and the force of those repetitions are directly proportional to the insult to the tissue, and inversely proportional to the amplitude and the relaxation time. And so that's a basic model. In fact, there have been others that have worked on these models for repetitive motion that you really use a lot of different factors. An example of that would be NIOSH's lifting equation and the multitude of factors that take place in that particular formulation. So what I want to discuss today, there's a lot of joints involved in these repetitive motion injuries in sonographers and providers who utilize ultrasound. I'm only going to talk about one of those today in terms of the lumbar spine, because I wanted to use it as the example or the platform for you to understand how these injury patterns occur. So with spine movement, if you look at the spine has a wide range of movements. You can flex, extend, you can rotate, and you can also do some side bending as well. And so because of that, there's a lot of potential for injury. So these are the basic movements. The first 50 to 60 degrees of flexion occur in the lumbar vertebrae, and then beyond that is due to an anterior pelvic tilt. And this has repercussions on repetitive strain injuries, which I'll show you now. So in normal standing, the line of gravity passes straight down through the lumbar vertebrae. Okay, so as you move into a flexed position, the center of movement moves anteriorly, and so that puts much more pressure on areas that aren't designed to withstand repetitive motion injuries or repetitive motion patterns, I should say. And so, when you're in a slightly flexed position and you repeat those movements, and if you have a load, you can see that load is translated onto the anterior discs of the lumbar vertebra, which tend to cause a displacement or a herniation posteriorly, which we'll also discuss in a few minutes. So when you talk about loading the spine, these are just examples of different loads and how you can kind of graphically depict it. But so when you're standing upright, the percent of the load on the L3 vertebra is about 100%. When you're in a sitting position, it's about 140%. When you're flexed forward, it's more than 150%. And then when you sit in a flexed position, it's even higher than that. And so this is where, especially in sonography, you can see how lumbar spine injuries occur because you're putting an extra load on the disc. Most sonographers don't sit back into an extended position with lumbar support when they're scanning. In fact, they're more bent in front of the patient and extended with their arms extended as well, which I'll discuss in a few minutes. So this is when the disc pressure is the least. You can see in D, in the letter D of that pictorial, when you're in a slightly extended position with lumbar support, the disc pressure is the lowest. In fact, it's the highest when you're in an erect position, which is what I just talked about. And when you're slightly flexed and bent forward, there's actually more disc pressure than at any other point. So that brings us to basically the meat and potatoes here, which is the background on how these injuries occur. So, the range in the survey work that's been done over the last 10 to 15 years has indicated about 80 to 90% of sonographers get injured at work. 20% of those, and these are all self-reported surveys, 20% of those eventually experience a career-ending injury. And obviously, shoulder pain is the most common complaint, with neck pain being the second. And interestingly, if sonographers make it past their first 5 years of work, they actually present in different injury patterns than new sonographers or somebody with less than 5 years of work. In fact, they present with pain in the wrist, hand, low back, and fingers. And those are the same risk factors that we see in a multitude of industries that have these same type of work injuries from repetitive motion or repetitive motion patterns. So historically, about 57% of sonographers fail to respond to their symptoms. In a study that one of the PIs, Dr. Christine Robinson, and I had just completed, actually, we found that ultrasound fellows actually don't report their symptoms at all to their program directors, and certainly don't report them as work-related injuries. Less experienced sonographers take less time off than seasoned sonographers, and there's probably a cultural reason behind that, i.e. they're concerned about preserving their job. And if we're looking at some of the objective data now, this is the data from the Bureau of Labor Statistics. the diagnostic medical sonographers, when they had a work-related injury, had about 16.3 days away from work on average per 10,000 full-time workers, which is the way that it's reported in the BLS data in 2014. Interestingly, in 2016, there has been an increase in the days away from work. And when we look at the occurrences really aren't that many when you compare it to other industries. And there could be a lot of reasons for that. I mean, the survey data indicates the injury rates are much higher, but then we don't have that transparency or that correlation in the BLS data, which makes me wonder if there's underreporting of these injuries. In fact, the interesting part of some of the BLS data, which I thought was probably the most resounding, was that 29% of these types of repetitive strain injuries that resulted in lost work time actually resulted in a lot of days lost. So 11 to 21 days in about a third, and then the other third was 31 days or more, where the median number was about 13 days. That's a lot of days off from work from these repetitive motion injuries, especially if you have multiple occurrences over a number of years. And so, you know, in terms of the body parts that were injured, at least reported in the data, you know, they correlate to what the survey data shows us, primarily shoulder, back, arms, and hands. So if you look at the Liberty Mutual data, which is probably one of the only data sets that we have access to from the workers' comp insurers, you can clearly see that overexertion injuries by far take up the most cost to our society. And so that's why it's very important that we, number one, prevent these injuries, and number two, treat these injuries with the highest level of evidence so that we could get people back to work and productive in society. So when we talk about risk factors for occupational work injuries in this particular population, what we're really talking about is repetitive movements. So what is repetitive movements? It really means people that are in a flexed shoulder and abducted position, people that use pinch grips when their wrist is flexed and extended at the same time or going back and forth, and where people are using their monitors and screens. Oftentimes when you're scanning the patient, you're scanning in an extended, your shoulder is extended, your elbow is extended, and your neck is rotated in the opposite direction. And if you think about how traction injuries occur, this is a primary risk factor for those types of particular injuries. And so, you know, as all of us know that are on the webinar right now, we all scan in awkward postures. In fact, we do whatever it takes to get the right posture so that we get the right view, so to speak, because the view is everything for us. And so oftentimes we will put ourselves in positions that allow these work injuries to occur. So using proper technique and ergonomics can really improve your workstation and help reduce some of these injury patterns. So other ways and other modalities when we talk about awkward posture is if we're using one side all the time. And so one-sided static work introduces another risk factor, as well as constant pressure with the shoulder abducted and the elbow extended, as I discussed earlier. Of course, scanning obese patients, because what does that do? That puts us into a shoulder abducted and elbow extended position. And also when we have contralateral rotation of the neck. And when we have to stretch in those obese patients with our transducer, that adds extra changes in the forces across the shoulder, which induces these types of injuries. Some other more abstract risk factors. We know that night shifts have complex ways that it affects our body. You know, it's not just in work-related musculoskeletal injuries, but working at night, you have a higher risk of cardiac disease. You have a higher risk of being injured on the way home, and that's all been kind of borne out in the literature. In fact, the survey data that's been published, it actually indicates if you have greater than 100 scans per month, you're probably going to suffer a work-related injury, at least have a risk factor for it. And of course, when you scan for 13 or more hours per day, it just makes sense. If you're scanning a lot, you have a higher risk of being injured, as well as the duration of scan. So oftentimes, if you're scanning multiple patients in a short period of time, you have a chance for your body to rest, and that way it's not constantly in an awkward position. But when you're doing scans for long periods of time, it puts more tension on the body and just increases your risk of injury. And when we perform bedside ultrasound, that in and of itself means that you're out of your normal work area. You're usually in a patient room and you're scanning that patient. So the room isn't set up ergonomically. And so that's why much of the literature indicates that this is a risk factor. And if you have a pre-existing degenerative joint disorder, that predilects you for injury patterns through this type of repetitive injury. Some clinical observations that I've seen, which has been borne out in much of the data, is that people that suffer these work-related musculoskeletal injuries oftentimes have rotator cuff injuries, whether that includes tendinosis, bursitis, partial tears, impingement syndrome, certainly cervical neck strain, which may or may not include tendinosis of the rhomboids, the traps. You can get facet joint arthropathy from that. I've seen that quite a bit in ultrasound sonographers that come in complaining of neck pain, and they have degenerative joint disease in their cervical facets, and really they've never had any other injury patterns other than their occupational work. This data hasn't been published. These are just my own personal observations. And in addition to that, we've seen quite a bit of lumbosacral strain, and I think a lot of that is from multifidus tendinosis, also some facet joint and disc disorders, and we also see it in those wrists. We see carpal tunnel syndrome, common wrist extensor tendinosis, and de Quervain's tenosynovitis. And don't discount the fact that many people will have concurrent injury patterns. So oftentimes you'll see a some type of cervical pathology as well as a shoulder pathology. So sometimes these injuries will run concurrently, and you just have to be aware of that. So there's a lot of strategies that we can help to avoid some of these disorders. We can do ergonomic redesign and prevention, which Tammy is going to speak about. But we can also talk about the levels of hazard control. Those include administrative controls, where you can rotate jobs, especially if you're doing bedside scanning. Make sure that you're rotating among the members in your group, so that there's not one person in particular that's doing all the bedtime scanning. Of course, you can administratively limit people's scan time and the duration of scans, and put break periods in, and always allow for some room turnover, because when you have time to change the room, you have time to ergonomically change the room to fit the next patient, because there's not one fit all proposition for each patient that you'll find that have that can reduce your ergonomic injury. But instead, you probably need to look at your schedule ahead of time and know what's coming, so that way you can improve the room and the space to allow you to scan appropriately. And then rotating your shift schedule for a reduction in nocturnal duty hours is very important. And just as an occupational medicine pearl, the better way to shift in the schedule is to move forward slowly in time. So going from the morning shift to the afternoon shift to the evening shift is actually a healthier way to design your transitions. So when we talk about those injuries and the types of injuries we have, there really is a disparity in the literature and what's reported in the BLS data. And I really think the reason is because we're underreporting these injuries. And there's probably a lot of reasons for that. So what do we have to do to improve that? We need to educate our community. We need to increase our transparency. And we need to have better oversight, both personally as well as administratively, and we really need to change the culture. So how does that happen? Well, it happens through a multitude of ways. First of all, we need to communicate that these injury patterns are real, that they're occurring, and that there are people that can help us with this. And so, there's federal regulation in terms of the Department of Labor's Occupational Safety Health Administration. there is a duty that all industry has to provide workers with a safe, a reasonable expectation for safety in the workplace, and that's provided by the general duty clause. And so, OSHA has already been assessing musculoskeletal disorders in many forms in many industries. Most recently in actually chicken factory workers, and so they've already assessed citations to companies that have these work-related musculoskeletal repetitive strain injuries, and it's just a matter of time until OSHA begins to look in other industries and start evaluating these types of roles and the roles of industry to help to self-regulate themselves. That's one way that OSHA can act. They can act on citations, and they don't just act in an industry-wide fashion, but they also act when you request them to act. So that is always an option. If you feel like your institution you have a lot of work injuries that are related to repetitive motion, you can always ask OSHA to come in and do a site visit. Excuse me, and they'll do that, and they'll do that fairly. I've been part of that before, and it's not done out of maliciousness, but instead it's done to protect the worker. And there's also follow-up inspections that they will do. So why don't we see a lot of these injury patterns clinically, and why are they underreported? Well, in terms of workers' compensation, it's a difficult system in general, and it's very difficult to adjudicate. And the reason that is because medical causation in the context of workers' comp really has two parts. The first part is the worker has to prove the injury, which has to be a medical condition, and you have to be able to prove causation, which means that it has to happen at work. There's two parts to that evidence. It's factual, based on what you report the story as, and then there's the medical evidence, which is provided by the clinician or the physician. And so the problem with these types of injuries is there's not really an inciting event. When you fall down a staircase or something along those lines and you have a fracture, well, that's an inciting event. And so workers' compensation tends to recognize that much easier. But when you have these repetitive strain injuries, there's not really one event, but it's a cluster of events that occur simultaneously through some period of time that actually cause these symptoms, this symptomology that you may suffer from. And so one problem, with determining these claims is that you have these secondary degenerative disorders that you may or may not have from a lifetime of work, or from if you had a career, beforehand, if you played sports or were in athletics. And then there's this issue of variability in state-to-state workers' comp system. Each state views claims a little bit differently. And not just that, but each insurer deems claims a little bit differently within the state programs. There isn't really good standardization across states or even across insurance companies. And so generally, for a claim to move forward, the physician has to give a definitive diagnosis, and it must have a conclusive opinion. It's tough to do that, though, and oftentimes. And so physicians, should really avoid speculative language. They should use definitive language instead. They should always specify their medical rationale, and based on reasonable medical opinion, that this is how I feel this injury pattern occurred. And you have to be able to talk about the period of impairment. If they believe that medical management will improve the symptoms that you suffer from, if you have any functional limitations, they need to talk about their work restrictions and their activities of daily living. And these are all things that occupational medicine physicians are particularly good at, and so hopefully you have one at your institution. There, in terms of a clinical interpretation, you really have to be able to present to your clinician with your initial symptomology. And so whenever you start to feel injured at work from the things that you're doing, you should begin to start keeping a log. You need to present to yourself to the supervisor or to the physician or clinician or the musculoskeletal specialist that you choose. You should keep a log of your scans, the type and duration of your scans, when your symptoms recur, what positions elicit the pain, where the pain is, and positions that make the pain better. And more importantly, when you're off from work or when you're on vacation, do your symptoms get any better? Are there any observed clinical findings? Do you have any, tendinosis under ultrasound or MRI? Do you have any bursitis? Those all help to form that clinical opinion that I just talked about. So you can always, in terms of how to deal with this, you can always request a consultation by your industrial hygienist or ergonomist. That's what they're there for. They're there to help you. So make sure you make use of that. And make sure that your physician is aware of any worsening of your symptoms, and please ensure that they're completing the required documentation. That's one of the hardest things in the workers' compensation system. The paperwork is endless, and so your clinician really needs to stay on top of what needs to be filled out, when it needs to be filled out, and you just need to make sure that you're on top of it as much as they are as well. And make sure you know your personal health history. If you do have a degenerative joint or disc disease, or you've had an injury in the past, make sure you disclose that, because if you disclose that ahead of time, then the claim will move much smoother, instead of having an investigation and people questioning how true your claim is or it isn't true. That's a argument that just doesn't help your case, so to speak. And if you continue to have problems in the workers' comp system, make sure you refer the case to your state insurance commissioner. Oftentimes, people don't even know there is an insurance commissioner in your state. So, if you're having problems in the workers' comp system, that usually is available in most states. You can always refer your case to legal counsel to help you, and you can always contact the National Institute of Occupational Safety Health, or OSHA, for any type of needs assessment. One thing that you can always use, if you don't go down the workers' comp route, you can always invoke your Family Medical Leave Act for personal illnesses or injuries. But you honestly shouldn't have to do that, since these are work-related injuries. So in terms of, we talked about injury patterns among clinicians, but we really haven't talked about it among providers. So recently we did a survey where 83% of fellows who perform 6 or more scanning shifts a month reported a work-related musculoskeletal complaint, where only 42% of those who perform less than 6 shifts per month reported similar injuries. So that's an interesting dichotomy. 90% of fellows who performed more than that number of studies per scanning shift reported a work-related injury, and 53% of those with less than 20 studies per shift reported those injury patterns. So those are just some numbers to kind of give you an idea of somebody is always looking for that number of scans per shift that will lead to injuries, and so I thought this was important to report it today. And this study is actually soon to be published. So the PI, again, is Dr. Christine Robinson, and we're looking forward to moving forward on that. So in terms of future research and advocacy, we have a large prospectively followed 3-arm randomized controlled trials is what we really need to determine what types of assessments work, what ergonomic redesign works, how to better diagnose these injuries initially, so that they don't turn into subacute or chronic injury patterns. And we need to be able to differentiate prevention strategies as well as those diagnosis and treatment strategies. We should form a musculoskeletal registry for ergonomic injuries. We've done that in a multitude of ways already. In the spine literature, there is already a spine registry where different organizations are contributing their case numbers. I think this would go a long way to understanding ergonomic injuries across industries if we were able to come together and do something like that. And we need to really engage our regulatory and scientific agencies. Remember, they're there, these agencies are there to help protect us, and those not just include OSHA and NIOSH, but our academic organizations like AIUM and ACOM, which is the American College of Occupational Environmental Medicine. So just in conclusion, what we want to do in sonography among our providers, among sonographers in general, is we want to be transparent. We want to be able to educate each other and make sure that we're reporting our injuries. We need to really get a hold on the risk factors and learn to minimize those risk factors. Institutionally, if you can do some type of hazard control analysis, that would go a long way to helping you. And engaging in better research to understand these types of injuries is really what we need to do. And we just all need to advocate for ourselves, for each other, and for our colleagues and friends. So with that, I'm going to hand it over. These are my references. I'm going to hand the talk over to Tammy to finish up here.
Thank you, Dr. Sayeed. You know, it is interesting to me that the first published account of ergonomic concerns with sonography, one of them anyways, was termed the sonographer's shoulder by Marvin Craig in 1985. A subsequent study in 1997 by the Healthcare Benefit Trust utilized data collected from almost 1,000 sonographers then practicing in the United States. Results showed that 84% of the sonographers at that time experienced musculoskeletal pain related to scanning, with neck, shoulder, wrist, hands and fingers, and back as being the most commonly affected sites. In 2003, the industry standards for the prevention of work-related musculoskeletal disorders in sonography were published. 15 years. I wish that we could say that in 15 years that we've made substantial gains in this area. And in some ways we have. Equipment manufacturers listened and they've made changes, practically redesigning the workspace of a sonographer. It has been noted that one of the most important pieces of equipment in an ultrasound workstation is an electrically height adjustable table. The structures of the past and manually adjusted tables, which most of us learned to scan on in the past, prior to this time, they were the norm in all of our sonography exam rooms. But they tend not to be suitable to be adjusted. They're not easily adjustable, so we don't take the time to adjust them if they can be adjusted. Ideally, the table should adjust in height from approximately 22 to 37 inches to accommodate both patient transfer from the wheelchair to the bed, and also to accommodate the variety of height and reach in our sonographers. Variations in the bed can allow, for example, a headrest for carotid and thyroid exams, or possibly retractable leg supports that allow for ergonomically correct endovaginal scanning. If exams are performed seated, an ergonomic workstation should also have an ergonomic chair that is easy to operate and adjustable from a seated position. Too often, the same chair is utilized in the sonographer's computer station at a desk. It's the same chair that we find in exam rooms. However, chairs designed specifically for the sonographer in mind has detailed features for different types of studies, providing support to the sonographer. The examination room must be designed with the purpose of the variety of exams that will be performed. Some examination rooms will offer carotid exams on one patient, then an endovaginal exam on another patient, and perhaps maybe an echo on the next patient, all in the same room. So the exam room must be large enough to allow for free movement of the equipment in the room to allow for a wide variety of equipment setup. Lighting should be easily adjustable. It is suggested that a good ergonomic setup in a room is 150 square feet. This takes also into account any additional structures, not including our ultrasound machine, our bed, or our chair. One of the last spots, perhaps, in a sonography department is often the computer workstation. In today's world, with the ability to manipulate the image and post-processing, in addition to the patient information that must be recorded, more and more time is spent at the computer workstation. Here are some images of some typical workstations that may be seen. The first image demonstrates a mouse too far away, requiring the sonographer to continually reach for the mouse. The second image has a monitor that is at an angle, requiring the sonographer to strain eyes and neck to view. And the last is an image with the counter too high and legroom interference. We have to keep in mind that the continually and repetitive use that the workstations experience, in addition to a variety of heights of the people that will use them. Ideally, the table would be adjustable. The top of the monitor is positioned straight and should be at eye level, being at arm's length away with the mouse close to the keyboard. There should be adequate leg room under the desk with a height adjustable chair. The keyboard should rest in a keyboard tray with a reverse tilt, allowing for the wrist to be in neutral position. Lighting, again, should be easily adjustable. The sonography machines themselves have been redesigned to allow for ergonomically performed exams. Monitors have been designed to be more mobile. Equipment has been designed to accommodate variable heights. Transducers have been designed to be more lightweight. The cables are lighter than when we first started. Additional supports have been developed specifically to help sonographers establish and maintain a neutral body position. Significant changes have been made within our profession to help facilitate the ability to perform ergonomically correct exams. As a profession, we have made gains in these areas. But despite these improvements, however, a 2009 study indicated 90% of clinical sonographers experienced symptoms of work-related musculoskeletal disorders, an increase of 6% from the 1997 study. Today, the topic of our sonographers scanning in pain or being forced out of their beloved profession due to repetitive injuries continues to be perhaps the greatest challenge of our profession. From social media to requested lecture topics, work-related musculoskeletal disorders continues to dominate our discussions. It could perhaps be said that only 10% of us are not scanning in some form of pain. As we look into the variables that increase the risk factors, we have to acknowledge that there are many risk factors that come into play regarding a typical day. For example, not all sites are utilizing the most up-to-date ergonomically compliant equipment. Portable exams continue to be a reality of our profession, requiring exams to be performed at the patient's bedside, requiring us to manipulate our bodies around equipment and machines in order to perform the ordered exam. As healthcare continues to swing in a pendulum path focusing on maximizing the number of exams completed, increasing exam counts continue to be an ongoing issue within our profession. In addition to added exam numbers, the patient population within the U.S. continues to become a population that is difficult to scan due to increased patient body habitus. These are all the realities in which we scan, in addition to being short-staffed, having minimal breaks, and rest time, as we have seen our profession shift even further into the use of computer workstations. The breaks our bodies might have taken in the past as films were ran in the dark room and conversations were to be had with radiologists are now in most places a thing of the past. Output, efficient patient flow, profit margins continue to be part of our conversations that concern our profession. And yet our bodies continue to scan in pain every day. Perhaps one major change that we have not seen as a cultural shift within our profession is the adaptation of preventative and therapeutic exercises. The exercises have long been identified, distributed, and encouraged, yet exercise stations remain empty. Even though there are many variables that we either cannot change or the wheel of change is incredibly slow, exam counts, length of exams, the size of the patient, and to an extent the equipment on which we scan, but we can control how we prepare our own bodies for the day ahead and how we scan, which will perhaps alter the path of our own personal careers. Here's what we know. A primary causative agent of work-related musculoskeletal disorders is due to repetitive physical risk factors day in and day out. Many of them are related to our own personal scanning techniques. Perhaps it was the way we were taught, how we can do it the fastest, how we are most comfortable. Some of us are still scanning in the same position that we started scanning over to 20 or to 30 years ago. We aren't allowing ourselves to adapt to the new equipment or the information, whatever the reason. If we are scanning this way, we need to adjust our bodies so that the risk factors are minimized. We will always have those exams that are outside of the norm, that will require some, for lack of a better word, acrobatics to complete. However, if they are the exception instead of the norm, we can protect our bodies and our career. As we are setting up our exam room and preparing for the exam ahead, we need to mentally check off how we will be scanning the patient. Arm abduction needs to be less than 30 degrees, check. Monitor needs to be set at eye level, check. My body has to be in a neutral position with no twisting or bending. How am I going to move the patient to make this happen? Check. So this can all be assessed before we even bring the patient into the room. Then as we begin to scan the patient, we need to be aware of when the variables change and how we need to adjust to stay within our preferred body position. It's a constant dialogue. When we initially look at this example, some of us may have just spent half of our day scanning just like this today. However, when we run through this mental checklist with this exam, we quickly realize that the arm is abducted greater than 30 degrees. We know that when the arm is abducted like this for long periods of time during the workday, it can result in a diminished blood flow and muscle fatigue, which will eventually lead to pain and discomfort. We must be aware that when we scan with our arms not abducted at an angle greater than 30 degrees between the torso and the upper extremity, this can easily be corrected by bringing the patient closer to us, decreasing the amount of distance between us. Here's an alternative way to scan a left leg venous exam. We know that overreaching, such as to perform a left leg venous exam in a typical setup, causes us to use the muscle in our shoulder in a static posture, which can impair blood flow to the shoulder muscles. We can make adjustments by bringing the patient's position, changing it completely, putting the leg to be scanned closest to us, as demonstrated in this image, allowing us to stay closer to a neutral position. We can also adjust the bed or ourselves to lower our arm or support our scanning arm. When an exam requires that our arm be abducted past 30 degrees, we need to try to find an alternative position either for ourselves or for our patient. When we run through the checklist here, we see the arm is well within the suggested less than 30 degrees. The monitor is at eye level and the body is in a neutral position. This is a good setup. And this also demonstrates why it's important to have a room or workstation big enough to be able to manipulate how the patient is laying and where your machine is. Here's an alternative position for a right-handed echocardiographer to avoid scanning over a patient's back, thereby decreasing the overreach involved. Going through our mental checklist again, the arm is not abducted greater than 30 degrees, monitor is at eye level, and the body is in neutral position. Again, a good setup. Thyroid and carotid exams are also common exams that require overreach if scanned with the patient supine. An alternative would be to perform the exam with the patient in an upright position. The arm is not abducted greater than 30 degrees. The monitor is at eye level and the body is in a neutral position. This can even be a better tolerated position for patients who have had a stroke or have difficulty lying flat, making it a more comfortable patient exam. As we are evaluating our bodies for a neutral position, one place to always evaluate is our neck. Neck twisting, flexion, cervical protraction, especially as we're trying to concentrate closely to that image, they continue to be issues of sonographers as we utilize the images on the monitor to help us to visualize the structures in the body. The new machines allow us to manipulate the monitor to adjust to our personal height and the type of exam to decrease the repetitive injury to our necks. The monitor should be positioned directly in front of you at a height that you are looking at the top of the monitor, allowing for a comfortable neck flexion of about 15 to 20 degrees. Twisting of the trunk and repetitive bending of the trunk, as demonstrated in these images, is another area of our body to evaluate for neutral positioning. Twisting and repetitive bending increases pressure and shear forces on the intervertebral discs. We can minimize or eliminate twisting and bending altogether by adjusting the equipment so that it is closer to us so that we do not have to bend. It may be necessary to place the ultrasound machine at the end of the table for ease of access, have someone else to augment the leg in a venous exam, or even direct the patient to self-augment by flexing and extending their foot. Simple adjustments could bring these sonographers and these images into a less risky scan position. As we continue reviewing our checklist, I hope you're already, when you look at these images, the first thing you think is, you look at the arm abduction. Is the body neutral? Where's the monitor? Warning signs should be going off in our heads. Both of these images depict bending and twisting of the trunk. The machines and beds in these images could both easily be adjustable. Corrections can easily be made by raising the table and equipment to decrease the distance from the patient and the sonographer. The monitors could be raised up, thereby decreasing the amount of flexion of the patient's neck. I remember perhaps one of the most difficult scans for me to do was an endovaginal scan. At 4'11", I frankly didn't have the reach to do the scan and manipulate the keyboard. It was difficult at best, and it was a hard exam for me to scan, and frankly painful if it was a long exam. When I mentally go through the checklist on the setup of my past endovaginal rooms, both my arms were abducted past 30 degrees. Yes, I was twisting, and the monitor was way beyond my eye level. I scanned for years this way until I was shown an alternative way that got the same results without hurting my body. Endovaginal exams completed at the foot of the bed instead of at the side with the machine up by the patient's head. The machine should be pulled close to the imager, decreasing the amount of overreach and twisting involved in the exam. In this image, the monitor is at the correct height with the top of the screen to be at eye level, and this position satisfies our checklist. Once scanning properly, our attention then needs to turn towards how we handle our transducer. Deviation, flexion, or extension of the wrist increases the pressure in the carpal tunnel and compresses the median nerve. In addition, the image on the right demonstrates the cable cord draped over the sonographer's neck, which is exactly how I learned to scan as a student some 20 years ago. And I have to admit, it was a very hard habit to break. But once I made myself think about it and go through the checklist, put my cord in a support instead of around my shoulders, I could tell a difference when I would scan. Ideally, the grip to the transducer should allow the wrist to be in neutral position. The cable cord can be held in place with a cable support on the forearm. In addition to the neutral position, the grip to the transducer utilized should be a palmar grip instead of a pinch grip. We know that the pinch grip increases strain on the forearm muscles. It takes 5 times more strength to hold a pinch in place than a palmar grip. In this image, the forearm is also supported, relieving stress on the shoulder muscles. There's a lot that we've learned in the last 20 years regarding best practices in scanning. The knowledge combined with the availability of ergonomically correct equipment make it possible to adjust and scan in a less risky environment. Too often, however, the chairs and supports are found stored up in an empty room or closet instead of being utilized. Updated beds and monitors aren't utilized to their full potential, as we just don't take the time to adjust them as needed. Due to the shortage of time, space, many of us continue to scan without properly preparing our bodies for the day ahead, nor cooling it down at the end of the day. We don't prepare our muscles, protecting them. Much as a runner, whether it be a marathoner or a sprinter, old or young, they both stretch to warm up and then also to cool down. Perhaps we could alter that percentage number of those of us scanning in pain if we would make the suggested exercises and stretches non-negotiable and simply part of the routine of our day. It would be so much easier if the directive would come down from the top, requiring a decrease in the amount of patients that we scan per day. However, until that day comes, we cannot stay as we are in a holding pattern, waiting on others to protect us. We have to choose to be proactive and protect ourselves and the profession that we have chosen. In addition to best practices of scanning, there are many exercise programs out there. They all focus on the same core area. We need to find one and commit to doing them daily. We need to make the scan position adjustments, run through our mental checklist, take our scheduled breaks and lunches. Yes, we may have a patient waiting. Yes, we may have just added on more exams than we started with today. But without respecting our own bodies, we will find that others will not. We're going to have to go through a few basic stretches. We're going to go through a few basic stretches that will help you possibly incorporate in your day. If you haven't done your stretches today, I encourage you to join us. I'm guessing that there are several out there who haven't. Go ahead and join us as we go through them. This is a forearm extensor stretch. You're going to start by pushing your shoulder down and back, then externally rotate your shoulder. Once in position, apply pressure to your opposite hand and begin to stretch both forwards and backwards. And you want to hold these stretches for about 30 seconds. You don't want to pull past the point to where it's going to be painful, but a nice gentle stretch, both forward and backwards. And then you'll switch to the other side. There's also a lateral side flexion of the neck. This stretch highlights your sternocleidomastoid muscle. You want to keep your neck as long as possible while slowly dropping your ear to your shoulder. And just relax in that position for a moment. You can even progress the stretch by being seated on a chair and grabbing the bottom of the seat. Again, you want to hold for about 30 seconds, not pushing yourself past the point to where it hurts, so just where you have a nice stretch, and then you want to switch to the other side. You can also do a neck rotation stretch, also to stretch the sternocleidoid muscle. Slowly rotate your neck while keeping your chin elevated. For a deeper stretch, apply pressure with the hands opposite from the direction you're rotating. Again, a nice stretch. Hold for about 30 seconds, and then switch to the other side. To stretch your side deltoid, you want to bring your arm across your body and lightly apply pressure to increase the stretch on your shoulder. Hold for 30 seconds. And then you'll switch to the other side. To stretch your pectoralis and latissimus dorsi, position yourself far away from a wall, placing your body parallel to the ground. You want to bend at the hips and keep your spine straight. Push your chest forward, creating a slight arch in your upper back. And stretch your lats and chest muscles. Again, you want to hold for 30 seconds. You can also do a chest stretch at the wall. You'll work your pectoralis by facing the wall with your thumb up. Slowly rotate away from the wall to stretch your chest muscles. These are just a few of a long list of stretches that you can do. You can easily see how they can be incorporated into your everyday practice. Clinical instructors and supervisors, I set up an exercise station with posters and all the exercise material in the room needed, from bands to small weights, at each of my clinical sites. My students had an exercise station as one of their daily responsibilities while in the labs and clinical rotations, trying to encourage daily habits for their future careers. As experienced sonographers, we can change the culture of our profession. There are very few times in our life that we can truly impact generations. This is perhaps one of them. As lead sonographers, managers, clinical instructors, those less experienced than we are, they're watching us. They may not show it, and depending on their generation, they really may not show it, but they really are watching you. They're seeing what you do. If you don't do your exercises, if you laugh them off, so will they. So let us be that example that takes the safety of our bodies and the safety of our team seriously. Let the change begin with us. Let them see us take time to do our exercises. Let them see us take our required breaks. Let them see us make the necessary changes on our equipment. When we start manipulating the equipment and moving the monitor and setting up the station the way we need it set up to scan properly, so will they. It's interesting. It doesn't take very long to establish a bad habit. From the time we first begin scanning with the cord draped across our shoulders to when we begin reaching to scan our patients, we quickly begin to develop our art of scanning. Each one of us is unique. And I think that's what drew a lot of us into the profession of sonography. However, for us to change, it's going to take purposeful and intentional actions to scan different. To change means every day integrating stretches and strength building into our daily practice of scanning. It can be overwhelming to change all at once, or perhaps you work in a clinic or department that doesn't have the most up-to-date props and support. But I encourage you to start changing what you can. Maybe just add one exercise a day. Maybe do them all. Before you place the transducer down to scan, do a quick checklist of your body. Is it in the most neutral position it can be in? If not, what changes can be made? Remember that there are times when we are probably going to have to manipulate our bodies to scan those hard to reach patients, whether they're in the NICU or they're in one of the units. But let that be the exception, not the norm. And then let's change so that in hopes that the next 15 years will yield healthier and experienced sonographers being able to be the best that we can be for our patients and our profession. Thank you.
Excellent. And now we have a few minutes for some questions.
All right, great. So it looks like we have a few questions. Let me read the first question out loud so that the audience hears. And our hospital has about 25% of the sonographers with reported injuries. Most sonographers choose to work 4 10-hour days. It sounds like the industry recommends 8-hour days, but our sonographers insist that they do better with more days off. Do you have any recommendations between an 8 or 10-hour day? And so, you know, I wish I could answer that question with you know, a strong support of the medical literature. Unfortunately, you know, between 8 and 10 hours, you know, there's still the 13 hours is what's been supported in the literature. So at 13 hours, you have an increased risk of injury. You know, many peoples and across many industries will work a longer day to get that extra day off, that third day off. And actually, in the occupational medicine literature, this has been supported as a better rest period for workers. So, you know, based on literature that's outside of sonography, I would probably say that that would be okay. But you know, I don't have a medically based answer to that, at least supported in the literature, specifically for sonographers. The next question is, you know, there's an issue of peer support and whether or not we have any recommendations how to get sonographers together as a team to help support each other. Tammy, would you mind answering that question?
Sure, I would love to. What I would suggest would be trying to find a way to incorporate let's keep everybody safe in our department. So maybe do an informal study in your department. How many people are hurting? and then start with that percentage, and then take a month, take 3 months, take 6 months, and then incorporate exercises into your day and make it a group activity. And then in a month, in 3 months, at 6 months, reevaluate what your percentage of people scanning injured are. Are you getting better? Are you seeing differences? And then start making changes in your department as you need to. Reward, when you get your exercises all done. Try to find a way that exercises become a positive thing instead of how many exams can I get done today or who scanned the most today. And try to make it more a team effort to try to get everybody healthy.
Perfect. The next question is, in terms of the registry, since shoulder injury is the #1 injury pattern, perhaps a shoulder injury specifically may be the way to go. And I am in favor of registries, to be quite honest, because that helps to build the medical evidence. So, we do this in multiple areas of I'm an interventional pain physician, and so when we see these spine registries that have formed over the last year or two, we're really looking forward to the evidence that produces on types of disorders, types of treatments that work well, how the disorders came about, what type of degenerative components are involved. And that's really what we need when we talk about ergonomic injury as well. Specifically in the shoulder, I think it's a great idea. The next question is, if you're a left-handed sonographer, and Tammy, I'm going to let you answer this question. If you're a left-handed sonographer, how can you make an ergonomic redesign take place if you're left-sided dominant?
You're going to do the same thing that a right-hand dominant sonographer does, just mirror images. So instead of scanning on the right-hand side of the patient, which we typically scan as a right-hand sonographer, I'm going to move everything to the other side. And I'm also going to reevaluate depending on the exam I'm doing. It's all about my body. So I am shorter, so I have to change and keep my body at a neutral position in a different way than somebody that's 6 foot. So think about before you start your exam, before you do it, the way your patient's going to lay, where you typically scan. How can you reposition yourself or the patient or your equipment in order to keep your body neutral, in order to keep that arm abduction less than 30 degrees? I even would suggest practicing on your coworkers or trying it out before you get a patient in there. And you'll be surprised. You can, manipulate the ultrasound, the monitor, the machine itself, the keyboards will go up and down. Whatever you have to do to move, go ahead and try that to see if you can keep yourself neutral.
Great. So there's a couple of quick questions that I think that we can answer very timely. But so the one question was, have you heard of therapeutic massage or massage in the workplace? And I can tell you, I wish that more institutions did this because I would take advantage of it. But in truth, there aren't a lot of institutions that do this. There are some that are very progressive that allow these to happen in the workplace. Oftentimes, it's very difficult to get this unless there's a wellness program that's part of your institution's workflow or workday. The literature, has really started to come together on wellness in general in the workplace, and people that enjoy coming to their jobs and have breaks to be mindful and to have coordinated care where they can exercise in the workplace. There have been some studies to show a return on investment. The question is, can you convince your institution to incorporate more of this into the program? And it will probably depend on the return on investment. So if you could demonstrate a return on investment of the wellness programs, then the institution will probably buy in. The next question is, do you have an image of the incorrect versus correct way to hold the transducer? And if I'm not wrong, Tammy, you actually had an image So the palmar grip is really considered the best grip to hold a transducer because it's less strain. The pincer grip, which is the way I was taught when I first learned ultrasound, because you can have a little bit more freedom with the transducer. I actually have found that the palmar grip will allow you to have the same amount of freedom with the transducer as the pincer grip, and it's better ergonomically for you. The next question was, Tammy, can you comment on if there's any posters of the stretches that you discussed, or are there any booklets that as a resource that folks can use?
Absolutely. Looking at my resource page down at the bottom, I actually pulled a lot of images. Joan Baker, who I think joined us today, Sound Ergonomics has a great poster that you can hang up in your clinical sites, in your departments, and it has all the stretches and what you're stretching, and it gives good information there.
And I'll also say that the American Institute of Ultrasound and Medicine recently had a fantastic blog on how to prevent work-related injuries in the scan. I don't remember what month that came out, but it was fairly recently, within the last 4 months. Darcy, you may be able to comment on that as well. The next question was whether or not there's a mechanical device on the horizon, like a Da Vinci arm, that scanners, that ultrasound could be used without having the human involved. And I'm not sure how close we are to that. I have heard of some discussion and some testing of automated systems, but the question is everybody's body habitus is a little bit different. In order to get the right type of view, you'd have to have a system in place that could give you some feedback to the control arm of it, and I still think we're probably 5 to 10 years out from that in general. I think that wraps up the questions, unless you have any other questions, Darcy.
Actually, we've gone over quite a bit, so we're going to have to call it a night. But thank you very much. And on behalf of the AIUM and the SDMS, our thanks to all of you who participated in tonight's webinar. Please remember to take the post-test and the activity evaluation. And we hope you enjoyed this presentation and will join us again for future webinars. Good night, everyone.